indulge. Sorry. Yes. So, as we were discussing here, the respiratory tract infection, the viral diagnosis of respiratory tract infection primarily depends upon the PCR-based tests. These PCR-based tests could be the syndromic panels, which are available in which you diagnose an entire array of, the bacteria, including the fastidious bacteria and almost all respiratory viral pathogens. Uh, they are very good, excellent sensitivity, specificity. They have been increasingly being adopted by a lot of clinicians, by pulmonologists. But the major hindrance of these tests is the cost. The standalone PCR test cost ranges from about 3 to 6,000, whereas these multiplex syndromic panels, which are available, range from anywhere between 25,000 to 30,000. So, what is need of the hour, especially in a country like ours, other low and middle income countries where respiratory tract infections constitute a chunk of major infectious syndromes and also is one of the major cause of antibiotic usage. Cost-effective point-of-care tests can be used. Point-of-care nucleic acid amplification tests, and then newer emerging technologies like LAMP and CRISPR, which are being actively worked on currently by a lot of biotechnology developers. So, an indigenously developed intensively clinically validated, field validated point of care affordable tests is an option that can improve the accessibility to good diagnostic modalities for diagnosis of respiratory tract infections.
Right. Madhuri, in pediatric, of course, we need RSV, flu, COVID, as we just told. In
Yes, sir.
oncology, transplant, immunocompromised, and other special population, we need all the three. But majority adult, we don't need RSV. We need COVID, flu. Now, if you
Yes.
do, if you we have low cost uh, COVID test available, flu test available. If you do it separately, a COVID PCR and flu PCR separately, what are the technical challenges? From clinical side, I had sent two swabs. And what are other challenges if you do separately? Because cost is low.
So, technical challenges in performing the test, you mean, sir?
Yes. The
Uh,
manpower, the two PCRs.
yeah. Actually, sir. See, any setting up any PCR setup, I think most microbiologists will agree with me. Obviously, requires intensive infrastructure. It requires manpower that needs training. It requires reagents. It does require investment. So, sir, I could you be a little more clear, sir? What is it that you're
Yeah,
trying
because
to?
because what my point is, the existing triple PCRs, COVID, flu,
Yeah,
RSV
yeah,
is
yeah.
expensive, and many
Yes,
patients can't afford. So what I do
yes.
in my routine practice is, I take a
Mm.
COVID PCR swab and a flu PCR swab and send separately because COVID costs only 400, 500 rupees and
Yeah.
flu 800, 900 rupees. So
Yes.
total 1,300, 1,400 is low cost than the existing triple PCR available. But looking at you need two swabs, so we have to poke twice into somebody's nose. And laboratory, you have to run two PCRs, isn't it? So
Yes,
the
absolutely,
manpower
sir.
cost and
Yeah.
time.
Yes, sir. Sir, yes, manpower cost and time that is there, sir. But I is it that what is it that you're trying to advise a separate
Um,
PCR for everything, or would you
oh
prefer?
no, no. My problem is the money. Most
The
patients can't
problem is the
afford.
money.
Yes.
Yes. So, sir, the money will, sir, let me put it this way now. See, sir, you do a molecular testing, any PCR, setting up any PCR, sir, there is obviously investment that is going into setting up a PCR. You know, training the staff, using as much reagents, and doing multiple runs. That is obviously bound to, sort of going to happen.
And also the patient's cost wise, the reason is cost from a patient perspective.
Yeah, yes,
If
sir.
I current existing PCR, triple PCR cost 5,000 above or 4,000 above anywhere. And even if you have a low cost PCR, it will be 1,500, 1,000 to 2,000. So is will it be more cost effective? Because I don't need RSP for more adult patients. So can I send a COVID PCR separately and a flu PCR separately? but even then it's going to be 1,400 rupees. So instead of these two, can we do a triple PCR that is more cost effective and affordable? That's my question.
A
From
triple
an
PCR,
affordability patient's point
yes.
of view.
Sir, triple PCRs are available, sir. To my knowledge, sir, the export platform does offer a triple PCR which tests flu, RSV, as well as the COVID-19. Sir, the cost effectiveness can be decided on the kind of technology that you're using, sir. Like you're saying, open PCR works cheaper, even if you're sending it singly because you're putting a lot of runs at the same time. You're testing a lot of tests with just one or two controls at the same time. But if you're doing a triple PCR, something like a nucleic acid amplification test, that obviously works out a bit expensive because, so the individual cartridges, individual primers, it's automated. So it's basically what you're paying for is for the technology and for the training, training the manpower. And I don't know, sir,
But
in
if
my
you have a
opinion, you can do it
if you
either.
have an
I think,
affordable
yeah, yeah.
affordable triple PCR, won't be that more preferable than individual COVID testing and flu testing?
Sir, absolutely, sir. That's what I said. Syndromic testing. Syndromic testing, it enables you to sort of in each run simplify what you're trying to diagnose. That is why I was sort of talking about why syndromic panels are so popular. These multiplex PCRs are so popular, which has primers for all the important pathogens. So, sir, depending on the technology that you're using, whether it is an open PCR, whether it's a closed PCR platform, like a nucleic acid amplification test, so the costing differs there. So it's depending on what your clinician's treatise probability is. What is it that you like to diagnose? What are you clinically suspecting? So based on your treatise probability, you have these array of options that you can pick from.
Right, right. And
I
Madhuri, we understand by hearing the noise behind you, we know how busy laboratories are. You know
yes,
how technically difficult are the need of manpower. I can see
yes,
people running behind you, big machines,
yes, sir.
and the need of manpower. And is it possible in majority government hospital? You have a big setup, we have big setup. What's the situation in ordinary government hospital, district hospital, medical colleges? Are they testing for these viruses? Yes, COVID, yes. But what about flu? What about RSV?
Sir, unfortunately, it's primarily no, sir. Uh, One thing, COVID 19 was one opportunity where everyone sort of upscaled their, molecular biology setups. But currently, the testing is just limited to COVID 19. I'm still, why just public sector hospitals? So there are still many private sector hospitals, even in major cities like ours, even in tier two cities that are still not regularly testing for flu or RSV. Perhaps COVID-19 was an exception because it was a public health priority. It was implemented from the government itself, is why even the tests are so subsidized. But otherwise, sir, the public, even the public, most of the public sector, even most of the private sector hospitals are still not getting, their influenza A. Currently we're grappling with influenza, at least in our city. They're still not getting it tested for. So in RSV,
Right,
there's even lesser, even lesser
tested.
request for testing. So that
Right.
itself is still a challenge.
Yeah. So RSV testing is very primitive actually, except in
Yes,
big
actually.
hospital like a corporate hospital like ours. And even flu testing is routinely not happening in tier 2 cities, both government
Yes.
and private. If you look at the NCDC's Integrated Disease Surveillance Network, there were around 13,000 cases of flu last year and 350 deaths. But we know that the real number will be
It's,
several times more than that. So
that's the gross
the number of the
underreporting.
flu cases in our country, the number of people dying of the flu will be so many times more than what is reported. Because we know that even in a corporate setup, we undertest flu. So what will be the situation in thousands or dozens of thousands of ordinary hospitals in the country, including government hospital? And RSV testing doesn't happen except in except research facilities and big corporates like ours. But RSV is needed for pediatrics. RSV is needed for oncology. RSV is needed for transplant. And that is not available in 99% of the government or even private hospitals in our country. That's the importance of affordable, accessible technology by our country. Vasant, we need your opinion on that.
Hello. Yes, sir.
We need your opinion on what can we do to make such tests available in majority of private hospital and majority of government hospital in our country. Our national policy doesn't recommend that. But don't you
So
think we need all the public, everybody, all the children, all the oncology, transplant patients, they deserve this test.
yeah, so I think as we discussed earlier, sir, the test should be available at point of care. It should be easily just like a rapid antigen test which we do or a rapid COVID test what we do. No, so I think we should the test should be available at a clinician's level. It should not be meaning if you want to really do this test and do judicious. But as I said, what we treat is tip of the iceberg. So if you really want this test to be available at all levels, family physician level, consultant level, tertiary care center level, it should be a easy test which should be possible to do at the bedside clinical in the clinic, and that is one. And second is it should be less meaning it should be cost effective, so that your treat that will not cut the money part for the patient. So one is it should be at point of care, that is in the clinic where you can do the test. And second is just like you have so many tests for doing malaria and all that. Now you can do the malaria test bedside to know whether P falciparum hai ki, whether it's a Vivax test. So similar test, if it is positive, at least it helps you to treat the patient. Negative, and if you're still suspecting it very high, then you do a PCR test. But I think two things: one is point of care, and second is affordability. I think these two are available, most important.
Yes, Vidya, Vasant made a valid point. If you really want to democratize this test in our big country, we need rapid point of care diagnostic test. But we are far away from that scenario. We are only started testing. Even in hospital doesn't happen. So if you have a low cost affordable test that the hospitals can use, majority of the private and government hospital can use, how can we popularize these tests? What can we do to convince people affordable, accessible respiratory tract diagnosis are needed in all our private hospital, in all our government hospital at least. Then of course later at the family practitioners level.
So I think, I mean, we're talking about three different viruses, but probably for flu, we have a good drug. So I don't think we need to convince people to test. Once you know that there is a good therapeutics available, then if the test is easily available, I think all of us will be willing to lap it up and test all our patients and give them the drug. It's probably, I would say it's similar in COVID, especially if you have a high risk host. I mean, now COVID is not a big problem, but still, if you have a high risk host and you are in, at least you want to test, or at least the patients now, because of the pandemic, they themselves want to know whether they have COVID or not. So that is another extreme where testing is not going to be a big problem. RSV, I think, is a situation where we don't have good diagnosis, we don't have good therapeutics. I mean, what is the point of testing is always going to be a big concern. Like whenever we say that you have to test for RSV, then maybe people who work in hospitals like us, we understand that there is the importance of the transmission and infection control and other issues which come up when we do not test, and when it just there is no isolation or anything happening. But other than that, probably this could be one way to look at it is, as Vasant was already saying, knowing the burden of these diseases in our population. I don't think we have any good estimates of what is going on in our population, and then that becomes the first trigger for us to know what therapeutics do we need, how do we what exactly is the hospitalization that we are looking at, how do we plan our healthcare delivery for that. So I think it is that is how I think I would convince people that they should be looking up to testing for these viruses.
Right. Yes. Vasant, what would you like to add on what Dr. Vidya rightly said?
No, I think she has said it well, and I think that is absolutely right what she said. So I think we definitely require point of care test as well as affordability. That is what is lacking. So 5,000 and all that nobody can afford. If you tell me to do the test, I might take oseltamivir and not do the test. And
Me too.
majority of the doctors would do the same thing. They will take the
Right.
oseltamivir and not do the test because the treatment is much cheaper than the cheaper than the test. So I think the test should be cheaper than the medication. Then only it works.
Right, right. Madhuri, see, we all know that we need respiratory viral PCR and diagnostic test in all hospitals in our country. But we are specialists. We are IDs, microbiologists. But don't you think the at national level, at policy level, we should introduce such tests in our national policy, should be available in government hospitals across all states. So what will be your advice for state governments and national policy makers about the necessity of having affordable respiratory diagnostics in all hospitals in our country, treatment pathways?
Right. So, so this the question that you asked has a very important public health implication. So, what you're saying is what public health, action needs to be taken for this. Like Dr. Vidya rightly pointed out, so we are still lacking the sufficient data, the sufficient numbers as to exactly how many infections we have. But the number that she sort of quoted was is already large enough. We are treating a lot of we are treating a lot of respiratory tract infections on without actually resorting to testing because of various reasons that Dr. Vasant also mentioned. So before we make it a part of a governmental policy or implement it into a public health sort of policy, sir, first of all we need to have diagnostics in place. We need to have good, affordable, indigenously developed, clinically validated, field validated. We first need to have those diagnostics in place. And to my knowledge, there are a lot of biotechnology innovators have already been, sort of working on it. The last I read was, currently there is no recent point of care test that is being sort of, that has reached its final stages for respiratory tract infections. But for UTI sepsis, and a lot of innovators have taken this into, one of their development projects. So, development of country specific panels, specific to country, specific to the burden of our infections. These affordable diagnostics first need to be developed. Once we have these diagnostics, which have been, which have been approved by the DGCIs, when we can actually roll it into, into the state and central government policies. First, we need to be,
Madhuri, I will just
yeah,
add a point.
yeah,
Of course, the best is point of care bedside diagnostics. But if we have affordable, accessible, accurate multiplex PCRs at a very low cost, won't it be useful at national level, government level, private hospital level? I'm talking about PCRs that can be done in the laboratory at very low cost.
yes, sir, it can be done, sir. We've done it for TB. In NTP, NATs have been made mandatory as a diagnostic modality to support the diagnosis of tuberculosis. And not just Cepheid, we have indigenously developed the TrueNAT as well. So, because the government decided to take the initiative to sort of make it a mandatory part of the diagnostic pathway for the National Tuberculosis Elimination Program, is why everyone is doing it now. So yes, something similar can be done for diagnosis of flu as well. For COVID-19 also, COVID-19, since it was a public health priority, it was decided to subsidize the cost, and the COVID PCRs are still available to us. So if you look at it, it is the cheapest respiratory PCR available to us right now. So yes, it's possible. With the current technology, yes, and for the future, we need to develop more indigenously, validated point of care diagnostic tests.
Right, right. Madhuri, as Madhuri stress, we need affordable, accessible diagnostic test where we can detect these common treatable respiratory virus. Vidya, you are one of the few pediatric ID consultants in the country. What will be your recommendation to central government policymakers and state policymakers on the need of these respiratory panels in government hospitals?
Sir, I think it's a little tricky right away to just go and say that we will have all these tests available, made available at all levels in the government hospitals, in the district hospitals. See, one thing is definitely it is going to be needed as a part of the treatment pathway for our clinical judgment and management and other things. For flu, we are going to be treating and other things. But when we talk about only looking at, say, other things like, say, infection control, stewardship, and all that, is the system is really going to take it seriously, and do we have the resources to practice infection control once we have a test which comes back positive, which is sometimes a big what do you say, it can sometimes be tricky even in our own hospitals when the system, when there's a large number of patients who come in suddenly during the seasons. We really struggle to isolate them and cohort them and other things. So the systems with existing infection control practices struggle, I say, during a large upsurge. But when we're talking about district hospitals or government hospitals where there are no big existing policies that I'm aware of, maybe during COVID they had a lot of things, but now when you don't have, and suddenly you bring in a new test with the principle that you're going to be doing infection control and isolating, I think that is a big, something big that we have to think about. Second thing is stewardship. There are, I think, equal number of studies which say that when the viral testing is done, antibiotics are stopped or they are not stopped. Okay, so I don't think, again, it again depends on the maturity of the individual system. How much are you going to rely on the test? What confidence do you place on the test? And how are you willing to stop an antibiotic just because a flu or a COVID or an RSV is positive? So it is going to involve a lot of system building, but I think that is the way forward. That is how we can progress as from, say, with a vision, and that's how we want India to be going forward, not staying at the same level that we are doing right now. So I hope if we can integrate all these things, it is something that the government should take it forward.
Very, very valid arguments. And Vasant and Madhuri, just following up the Vidya's valid arguments, when we wrote the National Infection Control Policy, which was guided by NCDC, our national policy of infection control, we wrote one statement in that policy: infection control is to the best of the ability. As Vidya rightly said, even in big corporate hospitals, infection control is a challenge. So what will be the scenario in ordinary government hospitals with inadequate resources, inadequate manpower, inadequate bed strength, inadequate isolation facilities? Of course, after COVID, situation is a lot better in government hospitals. There are facilities for isolation because the existing COVID facilities, they know how to do the job very well. And again, infection control will never be a perfect. It is best of the ability. So if you have this kind of test, at least it will help them. It will help the oncology patient, help your pediatric patient, help the transplant, and forget about the general mass of the patient. At least for specific population, they can, from infection control point of view, again, the best of the ability. If there are multiple patients, at least can cohort in one area, if not in separate, just like what they do in COVID. People are very familiar with isolation facilities now, and there are acceptable level of isolation facilities in most of these centers. And as you rightly mentioned, whether we stop antibiotics, it will be useful, but not to the perfect sense. But still, we should not deny the test if affordable. Of course, government cannot introduce this test unless it is very, very low cost. Very, very low cost. Cost is an important part for our, whether central government policy making process or state government policy making process. Vasant, what's your opinion on this? Policy making on respiratory panels.
Yeah, so I think it is one is so as Vidyansa you have pointed out, that's very important from the infection control point of view, and that will be very important. I would apart from infection control practices, of course these would be there. I'm looking at more of giving proper therapeutic treatment for this, because many of the patients may not receive oseltamivir when they want really, when they are influenza A positive and they really require it. So they may not be receiving adequate treatment. So there would be inadequate treat. We may not be treating patients who would be requiring also. I'm not saying that everybody should be receiving oseltamivir, but at least those patients who are high risk or having comorbidities or elderly population, they may be deprived of proper treatment when it is available in the market. Similarly, suppose if you have the same test kit which is testing COVID, if it is positive. And remdesivir being a very safe drug, and again in comorbidities or patients who are on immunosuppressants and all that, why should we deprive them of treatment when it is available? So I think there are two things. One is good infection control practices like antimicrobial stewardship and all that. But second is not depriving the patient of the medication what they really require to be given. So that, because we have seen, I really don't know which patient will behave badly, because we have seen 40 years females and 22 years male, on ECMO because of influenza A. It's a very sorry state of affairs, but it's very difficult to predict. But if somebody is running very high fever, toxic, then it is better to treat them rather than landing them on the ECMO.
Right, right. Even in adults, it's a serious challenge for us. And Vasant, I'll ask you one more question. How important do you think the flu vaccination is for adult patients, at least for special populations?
I think it should be a must for the patients with elderly above 65 years of age, and those who are on chemotherapeutic drugs or solid organ transplant. So this population definitely requires it. Second most important population, I would say, is the healthcare professionals. So vaccinating healthcare professionals is to prevent infection to their patients who are getting admitted in the hospital, so they don't fall sick. I think this two categories is a must. And third is, again, flu vaccine is optional for the society below 65 or 50 years of age. I would say it is optional. But I think these two categories, that is healthcare professionals and the patients who are immunocompromised by whatever extent, they definitely require it. Healthcare professional is very important, is from two aspects. One is preventing the spread to the patients, and second is not get the hospital not getting dismantling because of absence of healthcare workers not coming because of the flu. So if at a time, if there are in one department, suppose there is a CVTS department, and if out of 5, 4 are out of action for 4-5 days, it means a lot. Similarly, intensive care unit, if there are 10 intensivists, suppose 3-4 are also out of action because one spreading to the other, they also matters a lot, because the manpower also decreases. So I think from multiple angles it is useful.
Right. Vidya Krishna, are there vaccines available for RSV? Is it really, how important is to vaccinate against RSV?
RSV vaccine is available, and now it has already been introduced both in the US and I think UK just launched this month. So the importance is mainly, I think the first importance I would give is for pregnant women, so that, because only the maternal immunity goes on to the child till about 6 months or so. So maybe there it's very important. In the elderly, about 65 or 70 years of age, those extremes of populations, RSV vaccine is a huge. We have to wait and see how much of a game changer it's going to be, but I am thinking that it's going to make a big difference in hospitalization.
Right. Are they available in India?
No, sir, not yet available in India.
Not yet available in India.
Okay. India, yeah.
Right, right. We had a wonderful discussion. And are there any questions from the audience? Yeah, but Swapnil, do we have any database where prevalence of AMR is available? I'll ask that question. Yes, ICMR has got a network. NCDC has got a network. WHO, the GLASS system. These are all databases where we have excellent data of AMR in the country and at global level. Yeah, no, AMR is a serious challenge. That's a topic of discussion by itself. We can have detailed discussions on AMR and in different meetings. It's a big topic by itself. Any other questions from the audience? Thank you. We had a wonderful discussion. It was supposed to be a 1-hour meeting. We discussed much more than an hour. Thank you, Vidya Krishna. Thank you, Madhuri. Thank you, Vasant, for excellent discussion. We discussed very valid point, the need of affordable, accessible respiratory tract, accurate respiratory tract diagnostics for our patients in government hospitals and private hospitals. Thank you very much.
Thank you. Thank you, sir.
And
Thank you, sir. Thank you,
thank you.
everybody.
Bye bye.
Wonderful.
Have a nice day.
Bye.